Hey everyone, welcome back to the Deep Dive. Today, we're taking a close look at the American Academy of Ophthalmology's preferred practice patterns, for diabetic retinopathy, the ones updated in 2017. Big document.
Yes, it is.
We know you guys are busy, so we're gonna break it down.
That's right. We're going to pull out the need-to-know info so you can apply it right away.
Yeah, the most important takeaway.
Exactly. We're not just going to tell you what the guidelines say.
Okay.
We're going to go deeper. Like, why? Why these recommendations, the thinking behind them.
Yeah, I thought it was interesting how right off the bat they talk about bias. Like they really emphasize transparency with all the financial disclosures.
Yeah. 86% of the panel, no conflicts.
Wow, 86%.
Yeah, right? Gives you a lot of confidence in these recommendations,
Definitely.
But keep in mind, they're guidelines, not rules.
Right.
Each patient, each situation, it's unique.
Absolutely.
Yeah.
You got to use your judgment. Now, they get pretty technical, like how they arrived at their recommendations.
Oh, yeah. They're not messing around.
Combining those approaches from SIGAN and GRADE.
They're all about that evidence.
Right. All rooted in solid research.
Exactly. Like for me, what's really cool is they prioritize, those meta-analyses, the randomized controlled trials, the top-tier studies.
Okay, so let's just do a quick recap on diabetic retinopathy itself.
Right.
We all see it.
Every
Leading cause of vision loss.
Yeah.
In those working age adults.
Yep. And it can sneak up on you.
Right, it can.
Go from mild to severe, no symptoms, no warning.
And, it's important to remember type 1 and type 2 are different.
Absolutely. Type 1, often more severe complications, but early on.
Right.
Type 2, well, there are just so many more patients with it.
Right. It's like a numbers game.
Exactly.
Even if the complications aren't as aggressive, you're seeing so many more of those type 2 patients.
Right. So we've got to be on top of it.
Yeah.
And that's where patient education comes in. Big time.
Yeah.
The guidelines really hammer home that point, educate our patients about how it can progress without symptoms.
Right.
Get them in for those early exams.
Even when they're feeling fine, makes all the difference.
Huge difference.
Oh, and speaking of exams, table 3.
Yeah.
Super helpful. It's got the recommended eye exam schedule.
Oh, yeah. Bookmark that one. Based on diabetes type pregnancy status.
Yep. Got it all laid out.
So let's dig into the progression. The natural history of diabetic retinopathy, understanding how it develops over time. That's key for timely intervention.
Right. So it starts with non-proliferative or NPDR.
NPDR.
Then it can progress to proliferative PDR.
Yep, PDR. That's when things get serious.
And we know that the longer someone has diabetes, the more likely they are to develop retinopathy.
Right. But once they have it, what really matters? Glycemic control.
Right. So how well they manage their blood sugar.
That's the biggest thing we can influence, to slow it down.
Absolutely. So those talks we have with patients about their A1C, super important.
Super important. And of course, blood pressure control. Lipid levels too. Those matter.
Yeah. So they use that diabetic retinopathy disease severity scale.
The one we're all familiar with.
Right. To classify it, based on the
Yeah.
eye.
Minimal NPDR, mild, moderate, severe. It's a whole spectrum.
A whole spectrum. And then there's PDR, where you see those new blood vessels, the hemorrhages.
And even within PDR, you've got high risk and non-high risk.
Right.
Which totally changes how we manage it.
Okay, so now it gets really interesting clinically. Like, what do we actually do?
Right. So the document breaks it down, gives specific management recommendations.
Based on, how severe the retinopathy is.
Exactly. And whether there's macular edema or not.
So table 6 is our go-to, right?
Table 6.
Right.
That's our roadmap. It tells us, everything from how often to see the patient to what treatments to consider. Laser, anti-VEGF.
Like our diabetic retinopathy cheat sheet.
Exactly. Helps us make those decisions,
Yeah.
Make sure we're doing the right thing for each patient.
And it's interesting how treatment for macular edema has evolved. It's like anti-VEGF is taking center stage.
It really has.
For good reason, though,
Yeah,
right?
that's absolutely.
Yeah.
Those big studies like REA2, DRCR.net Protocol I, BOLT-T,
Yeah, those were game changers.
they showed us anti-VEGF can really make a difference, especially for center-involved macular edema.
Better than laser alone, in many cases.
Often, yeah. But laser still has a role.
Right. Like, what if a patient can't get to appointments as often for the injections? Or, they have other things going on. You got to think about the whole picture.
Always, always. It's about finding what works best for that specific patient.
Okay, so let's move on to the more serious stuff.
The severe NPDR, the PDR.
Yep. When things are are getting really advanced. What do we do then?
Well, with severe NPDR, the big concern is it progressing to high-risk PDR, so we got to watch them closely.
And then panretinal photocoagulation.
Scatter laser. That's our go-to for both severe NPDR and non-high-risk PDR, but timing is key.
Especially with type 2 diabetes.
Right. Got to be careful there. And we always want to make sure we've treated any macular edema before we do the panretinal photocoagulation.
Makes sense.
Yeah.
Address that first. Okay, what about high-risk PDR?
High risk. That's usually a prompt panretinal photocoagulation situation, trying to stop those new vessels from growing.
Prevent those complications.
Exactly. Hemorrhages, detachments, nobody wants those. But there's some new research that's pretty exciting. The drcr.net Protocol S.
Yeah.
It suggests that maybe, in some cases, anti-VEGF could be an alternative to laser.
Interesting.
We need more data, though, long-term data, to see how that plays out.
So it sounds like the laser's not going anywhere anytime soon.
Probably not, but it's good to have options, right?
Definitely. So what would you say is the biggest takeaway from this whole section? Like, if you had to boil it down.
I think it's the emphasis on individualizing care. These guidelines give us a framework, but each patient is different.
Right. You can't just cookie cutter it.
Exactly. You got to consider their specific needs, their preferences, their whole situation.
Absolutely. Finding that balance between the research and what's best for that individual patient.
That's what it's all about.
Yeah.
All right. So now let's get down to brass tacks.
Yeah.
How does this all play out in real life? With real patients. Let's talk cases in part 2.
All right, so welcome back. Last time, remember, we were talking about the general recommendations for managing diabetic retinopathy, but let's make this practical.
Yeah.
Real world stuff.
Exactly. So let's say you've got a patient, walks in, mild NPDR, no macular edema. What do?
Well, if we're looking at table 6, I'd probably schedule a follow-up in 12 months.
Okay, so we're not jumping into treatment right away.
Not at this stage. No need for laser or anti-VEGF yet.
But we're not just saying, see ya in a year, right? Oh, definitely not. This is prime time for those lifestyle changes. Get that blood sugar under control.
Right.
Manage the blood pressure and, really stress those regular eye exams.
Got to stay on top of it.
Exactly.
Okay, now let's say that same patient comes back a year later. NPDR has progressed. It's moderate now. And they've developed CSME.
Clinically significant macular edema. Okay, so now things are a bit different.
What do we do?
First, we got to figure out, is that CSME center involved?
Ah, okay.
If it is, the guidelines, they suggest thinking about anti-VEGF. Like, that might be our first line of treatment.
Makes sense.
Yeah.
This is where those big studies come in, right?
Yeah.
REA, D2, DRCR.net, Protocol I, all those.
Exactly. Those were really eye-opening, no pun intended.
They show that anti-VEGF can really outperform laser in a lot of cases.
Yeah, particularly for that center-involved CSME.
Okay, so anti-VEGF might be the way to go, but is there ever a time where we'd still do laser first?
Absolutely.
Yeah.
If the CSME isn't center-involved, or maybe the patient, they can't make it in for those frequent follow-ups that you need with the injections.
Right. Life gets in the way sometimes.
It does. And, you have to think about cost, insurance coverage, all of that.
It's a bigger picture thing.
Always. Gotta personalize it. Okay, so let's change gears. Imagine a patient comes in, severe NPDR and a vitreous hemorrhage. What's your next move?
Whoa, okay. That's getting serious. I'm thinking panretinal photocoagulation, right? Like, got to act fast.
I'm with you. We want to shut down those new vessels.
Prevent further damage.
Exactly. Now, sometimes you might even need to do a vitrectomy, to clear out that hemorrhage.
And if there's a detachment.
You got to address that too, of course.
So this is definitely a call in the reinforcements kind of situation.
It is. And it really shows you just how important it is to catch this stuff early. Early detection, timely treatment.
Can't emphasize that enough.
Can't. Every step of the way. It's about protecting their vision. It's about, quality of life. It's about more than just the eye.
You're right. It's a big deal. And it's not just about us as doctors, right? Like, there's a social and economic impact here.
Oh, huge. I mean, diabetic retinopathy is a leading cause of blindness globally. And the cost of treatment, it adds up.
Yeah. The guidelines, they do touch on cost effectiveness a bit.
And it's clear early intervention, it's not just better for the patient, it's better for the healthcare system too, saves money in the long run.
So we're really making a difference on multiple levels.
We are. We're helping people keep their independence, their ability to work, to live their lives to the fullest.
And that brings us back to patient education.
Always.
We've got to empower these patients to take charge of their health.
Absolutely. Make sure they understand what's going on, what the risks are, why it's so important to follow the treatment plan.
It's about helping them understand that, what they do every day, their choices,
Yeah.
they matter. It impacts their eye health.
It does. And those conversations, they can be tough.
They can, but they're worth it.
Oh, absolutely. And we're not in this alone, right? We got to encourage those patients to work with their primary care doctors, get that diabetes under control, blood sugar, blood pressure, cholesterol, all of it.
Teamwork makes the dream work.
Right. It's a team effort. And let's not forget the other folks involved,
Mm-hmm.
the optometrists, the diabetes educator.
Vision rehab specialists.
Yeah, the whole team. So, these guidelines, they can feel a little overwhelming sometimes. I don't know about you, but I've definitely had moments where I'm like, am I doing the right thing here?
Oh, yeah. I mean, every patient is different. It's not always black and white.
It's not. And things change, right?
Mm.
New research is always coming out. We got to stay on top of it.
Absolutely.
Yeah.
I feel like doing this deep dive it's a good refresher. Helps me make sure I'm up to date.
Totally. It's a chance to kind of step back and think about the big picture, talk through those tricky situations.
So speaking of tricky situations, I think it's time to look ahead. What about the future of diabetic retinopathy? Like, what advancements are you excited about?
I'm really intrigued by the new anti-VEGF agents they're working on, the ones that last longer.
Oh, yeah. Fewer injections. That'd be huge.
Right. Less burden on the patient, maybe better compliance.
I've also been hearing about those sustained release drug delivery
Oh,
systems.
those are
I
fascinating.
think those are going to be a big deal. Oh, I think they have huge potential. I mean, just imagine delivering medication continuously over, a longer period. It could really change how we approach chronic conditions like diabetic retinopathy.
Absolutely. It's a whole new frontier. And then there's the imaging technology too, OCT angiography, OCTA. It's really revolutionized things.
I know, right? Being able to see those retinal blood vessels so clearly, without having to inject dye.
It's amazing. It's so much better for the patient and for us, We can detect those tiny changes so much earlier.
Which means we can intervene sooner.
Exactly. Hopefully prevent vision loss.
So what about artificial intelligence? It seems like AI is popping up everywhere in medicine these days. You think it has a role to play in managing diabetic retinopathy?
Oh, I think it has a huge role, especially for screening and diagnosis. Think about it. Algorithms that can analyze retinal images super fast, super accurate.
That would be amazing. We could identify those patients who need to see an ophthalmologist much quicker.
Exactly. And with diabetes becoming more and more common, we need efficient screening programs.
Absolutely. I could also see AI being helpful for personalizing treatment plans.
Oh, definitely. It could analyze all sorts of factors, risk factors, disease characteristics, maybe even genetics.
Wow.
And then, boom, it helps us create the best treatment plan for that specific patient.
So it sounds like there's a lot to be excited about,
Yeah.
in terms of new treatments, new technology.
Definitely. It's a really dynamic field.
It is. But, beyond just keeping up with the latest and greatest, what advice would you give our listeners who want to steer informed, really hone their skills in managing diabetic retinopathy?
Well, the AAO is a great resource. Their website, they've got the full preferred practice patterns document there, plus webinars, podcasts, articles.
That's the great stuff.
Tons. And then there's the American Diabetes Association, drcr.net. They've got a ton of information too.
Both for doctors and for patients.
Exactly. And if you really want to dive deep into the research, the journals they're essential. Ophthalmology, retina.
Got to stay on top of those latest studies.
You do. It's all about lifelong learning.
I think that's a great takeaway. We need to stay curious, stay connected, and always keep learning.
Absolutely. And don't be afraid to reach out to your colleagues, talk to specialists, ask for help when you need it.
Collaboration is key. We're all in this together.
We are.
Well, it looks like we've reached the end of our deep dive into the AAO's preferred practice patterns for diabetic retinopathy.
It's been a great discussion. I hope it's been helpful for everyone.
Me too. And I hope it's given you some new insights to take back to your practice.
Remember, these guidelines, they're a great starting point, but they're not the be all and end all. Always use your judgment. Think about the individual patient. and never stop learning.
Couldn't have said it better myself. Thanks for joining us on this deep dive, everyone.
Until next time, keep those retinas healthy.
And don't forget to dilate, dilate, dilate.